Hey, CTEL team, don't let anybody in. I need to give Scott and Rebecca a debrief what we heard from Energy and Commerce. Is
Okay.
that is that
Yep.
possible?
Yeah, they're all in the waiting room. It's just Scott,
Okay.
Lydia.
Hey, Scott. So we just had, where's Rebecca? Is she signing on?
She's not in yet.
Okay. Scott, we just spoke to Energy and Commerce staffer, and they basically said, why are we hearing about this issue just in the last 5 weeks and not before then? I explained to them that there's what happened in terms of. Hello, my name is Krista Natoli, and I'm CTEL's Executive Director. CTEL is a 501c3 nonprofit research institute. We focus on all the laws, policies, and regulations that impact the delivery of virtual care. Under CTEL subject matters fit telehealth, remote monitoring, and artificial intelligence. Today, we have a special webinar with Rebecca Simone, a partner at Nixon Peabody, and Scott Brinks, former DEA chief. The title of today's webinar is The Future of Telemedicine Prescribing, Risks and Responsibilities. I'd like to hand it over to Rebecca to begin. Thank you.
Thanks, Krista. I'll start just by introducing myself. As Krista mentioned, name is Rebecca Simone. I am a partner in the healthcare group at Nixon Peabody, based out of New York. I am a healthcare regulatory and transactional attorney, very focused on digital health and telehealth clients. I have been very close to the DEA issues at hand and have been working with various clients from hospitals to medical groups to telehealth platforms on maintaining compliance throughout the public health emergency, the waiver period, and now another period of uncertainty. And thanks everyone for joining us today during this discussion. I'll hand it over to Scott to introduce himself and kick off our content.
Hello, everyone. I'm Scott Brinks. I am recently retired from DEA, where I ended as the section chief of DEA's regulatory drafting section. This is the section where we were responsible for drafting this telemedicine special registration that everybody has been waiting for again. I just have to give one disclaimer. I am no longer a DEA employee. DEA is requiring me to say this on all these calls. So we're going to get right into it because of time constraints here. We have some new information stuff that we want to share. First of all, I'm just going to go over a brief history of where we're at, just in case anybody has any questions. As everybody's aware, the Ryan Haight Online Pharmacy Consumer Protection Act was published in 2008, and this is where all these telemedicine regulations came from. And when this was published, it really did stop or almost stop all the online prescribing of controlled substance, for sure, the illegal side of it. Then in March of 2020, everyone is very aware that COVID happened, and this changed everything for us. In March of 2023, the DEA published the telemedicine special registration and what we call the audio-only buprenorphine prescribing rule. DEA received just an extremely large amount of comments to it, which kicked off of a lot of other issues with drafting this rule. In May of 2023, on May 11 of 2023, the public health emergency ended for COVID. And on that same day, DEA issued the first telemedicine flexibilities. And that was good through November 11 of 2023. And then due to the large comments that we got, we still couldn't get that NPRM through to finalize it. So we issued another extension for the flexibilities, which now is going to expire at the end of the year, this year. And that's kind of why we are at where we're at right now. Because of these flexibilities expiring, it's going to cause a lot of issues, which Rebecca will go over with you guys in a few minutes once I'm done here. But we kind of came up with three options on how we could deal with this and allow telemedicine to continue. The first one is Plan A, which is DEA could publish a special registration. That registration go through the comment period, and DEA could draft another final rule, and it could be done by the time the flexibilities ended. That is almost impossible for several reasons. Number one of them, there are so many guardrails in this new special registration that industry is not going to go for it. Number two, HHS has non-concurred on the rule. The White House could push the rule through, but they probably will not with the non-concurrence of such an agency like HHS. And then there's another one, the administrator can just extend the flexibilities. Then we have Plan C. We have a legislative fix. And this is where the new news came in. We were hoping that Congress would extend the flexibilities for 2 years by law. We just found out that the Energy and Commerce Committee said this is not one of their top priorities, so it will not happen by the end of the year. And then Plan C is we just need to get DEA to extend the flexibilities for another year. And that can be done by just writing into the DEA and putting a lot of political pressure on them. Those are the plans. Those are the go-ahead. The best one is to get DEA to extend these flexibilities, which everyone should work on. Now I'm going to turn it over to Rebecca to go over some of the consequences if this flexibility is expired.
Thanks, Scott. So I remain, despite some of the crystal ball tellings, I do remain optimistic that the current waivers will be extended. And maybe not for 2 years, but for some period of time. But I remain a realist, and I'm working with CTEL and Scott to ensure that prescribers of controlled substances and those that employ them fully understand the implications of a scenario where the waivers are not extended on January 1st, or any other, of the A, B, C options, which seem unlikely. So if the waivers are not extended, the law reverts back to pre-COVID Ryan-Haight Act. And at this point, it's been many years since we've had such stringent restrictions in place. And at a high level, the Ryan-Haight Act does not permit a provider to prescribe controlled substances to a patient unless that provider has first had an in-person visit with the patient. There are a few exceptions and a permissibility for a covering practitioner that I'm going to spend just a little bit of time on. But I just want to make sure everyone understands if the waiver is not extended and without legislative action, controlled substances essentially cannot be prescribed via telehealth unless the prescriber first sees the patient in person. And I'm going to get through what I have to say pretty quickly so we have time for discussion. So the Ryan-Haight Act does have a concept of a covering practitioner that may prescribe controlled substances to a patient at the request of another provider who has seen the patient at least one time in person within the last 2 years and is temporarily unavailable to conduct the evaluation of the patient. So even before COVID, before the PHE, working with very creative and smart telehealth clients, they'd asked whether this permits a sort of group practice model where one provider sees the patient in person and then another remote provider can continue to see the patient via telehealth and write controlled substances. The plain language of the covering practitioner permissibility does not indicate that that model works. To me, temporarily unavailable means that the provider that first saw the patient in person is on vacation, is disabled, or otherwise unavailable in the near future, and not that an intentional model can be set up so that the initial provider does not continue to see the patient. The first proposed rule from the DEA that Scott mentioned, the one that got 40,000 comments, permitted a referral model where a patient can see one physician in person and get referred to another, but that is not in the Ryan-Haight Act. That will go back into effect if the waivers are not extended. There are exceptions under the Ryan-Haight Act to the in-person requirement, one being a public health emergency, but only as specified by HHS and DEA. That's what we're operating under right now with waivers or with extensions. Another is a special registration pathway, which is yet to be set up by DEA and will hopefully be in a forthcoming rule. The only meaningful exceptions probably for those on the line here are where the patient is at a hospital or physically present with another DEA registrant. So for example, if your patient is at their primary care doctor who has a DEA registration, as most do, you can Zoom with your patient in the presence of the primary care doctor and provide a specialty consult and write a controlled substance script. That does not, however, count as an in-person visit for the remote prescriber. If the remote prescriber needs to write another controlled substance script for that patient in the future, the patient would again need to be in the physical presence of another DEA registrant. And again, thinking back before COVID, it really was not feasible to write controlled substances via telehealth without that first in-person visit. So that was a quick history lesson, right, about where we go back to if we have to turn back the clock on January 1st. And we have definitely heard the sentiment DEA rules be damned. We are not going to stop providing good medicine if the waivers don't get extended. We'll continue to prescribe via telehealth without in-person after January 1st. Totally understand that sentiment, especially for patients in rural areas or that are at risk, but there are legal and practical risks associated with it. So I'm going to kind of tick through those so everyone has a good grasp of what those risks really are. Starting with the legal risks, failure to conduct an in-person medical evaluation required by Ryan-Haight Act would be a per se violation of the Controlled Substance Act and can result in civil and criminal penalties. Most violations do not constitute a crime, and civil penalties do not necessarily lead to criminal convictions. And civil penalties can range from $10,000 to $100,000 per violation, which could be per script. A prescriber's DEA registration can be suspended or revoked. However, those actions are typically reserved for situations where the prescriber is found to be acting against the public interest or causing imminent danger. A likely easier case could be made for against public interest for Schedule IIs. And of course, if a prescriber's DEA registration is disciplined, that would likely lead to medical board action on the prescriber's medical license. If either a prescriber's DEA or medical license is disciplined, that can also lead to requirements to make disclosures to Medicare, Medicaid, and other payers. Now, on January 1st, let's say the waivers expire, is the DEA going to deploy agents to try to find physicians writing scripts via telehealth and discipline them? I can very confidently say no, and I think Scott would probably agree that you're not going to be out in full force on January 1st. There's going to be chaos and confusion, and it will take time to determine how the DEA will deal with the situation. And other than telehealth platforms, it's questionable how the DEA would even discover physicians writing scripts via telehealth if they're in the same state as the patient. But there are practical and logistical risks that everyone really should keep in mind and be prepared for. First, pharmacies probably aren't going to fill your scripts. They're not going to fill scripts for controlled substances that they believe are written via telehealth. It's not worth the liability for the pharmacy. We know already that certain pharmacies are denying scripts from out-of-state prescribers to limit their liability. And generally, just about every state gives pharmacies very broad discretion on whether they can deny scripts for red flags or suspicions of fraud. The only time a pharmacy really has to fill a script is in an emergency situation. Your professional liability carriers may not cover claims that are related to prescriptions for controlled substances via telehealth after January 1st. So if a patient sues and the injury is related to a script a physician wrote that violated the law, your carrier may have the ability to deny the claim, depending on your plan. There, of course, is risk of qui tam and whistleblowers. The DEA may not be out in full force on January 1st, but whistleblowers may be paying attention and can reach out to regulators on their own to report any activity that encourages violating the law. Payers are unlikely to knowingly reimburse for telehealth services that are related to writing scripts for controlled substances and could feasibly attempt to claw back reimbursement. So, what do we do now on September 30th about all these unknowns? As I said, I'm still optimistic that there will be some sort of Band-Aid in place, but put in place by the end of the year. But we can't ignore the risk of that not happening. For employers and hospitals, I would start thinking about messaging to your prescribers, letting them know that this is on the horizon, and there's a chance they will need to get their patients in for in-person evaluations if they have never seen them in person before. And that's important for prescribers that have seen the patient in person in the past. They can continue to prescribe via telehealth. They can also consider transitioning to other providers for prescribing controlled substances after January 1st. You can consider whether there are technological or logistical means for identifying patients that have never seen their prescriber in person, for example, through EMR. I have seen some telehealth platforms start to message providers asking about their prescribing practices, starting to create some sort of database to learn which patients may have issues receiving prescriptions in the future. For telehealth platforms that do not have a mechanism to see patients in person, the possibilities are much more limited, unfortunately. But thinking back to pre-COVID Ryan-Haight, can you get the patient in person with a DEA registrant for you to write a script after January 1st, at least while we're waiting out the forthcoming special registration rule. It clearly is not a permanent solution, but at least in January, can you get your patient into their PCP and do a telehealth visit with them while they're on site with a registrant? Keep advocating. Work with your industry organizations, reach out to government affairs resources, and assist in the efforts to put pressure on the administration and the DEA to do something now. I see we're like a little short on time. I'll add one more minor thing and then open up for discussion. But something that we didn't previously touch on, I think, in the last CTEL call on the DEA rules, because we were anticipating a forthcoming proposed rule, is the requirement that DEA registrants are registered with each state DEA office in which they prescribe. So, if you're in New York and you have a DEA registration in New York and you prescribe to someone in California, the requirement to also register with the DEA office in California. That requirement was similarly waived during the public health emergency and presumably continues to be waived, but without any extension of a waiver, that would also change on January 1st. And it's questionable whether a New York prescriber could even prescribe a controlled substance to a patient in California without a California DEA registration on January 1st. And that's another timing issue to actually get those state registrations before the end of the year, which, by the way, require a local practice address to be listed. And that comes with all sorts of hurdles on their own. So I'm going to pause there. Scott, if you have anything to add to what I just said, and then I think open to questions and discussion.
Yeah, I do have two real quick things to add. One thing I can tell you, as when I was leaving DEA on August 24th, we were told that DEA was not going to extend those flexibilities. So that's why the political pressure on DEA is very important. The letter writing, those do have an effect on DEA and they're important. So I encourage that. And then one person asked a question in the chat, how often should a prescriber see a patient? DEA does not have a required amount of times. DEA just requires that one in-person visit in order to do telemedicine. After that, it's not even considered telemedicine to DEA. Now, I do encourage you to check your state laws on what their requirements are, but DEA only requires one in-person visit in order for you to continue.
Yeah, I agree with that. The only indication of any time frame from DEA on how often to see a patient is under that concept of a covering practitioner. For the covering practitioner to be utilized, the practitioner that is referring over requested the visit needs to have seen the patient within the last 2 years.
Yeah, we just had another question, which I can answer in the chat box. If an advanced practice nurse with a DEA has seen a patient in person and recommends a stimulant, can the supervising MD prescribe it and be in compliance? Under the Ryan-Haight Act, you have to see that patient in person, and that patient belongs to you. It can't be transferred to another practitioner. Does anyone else have any more questions?
And encourage, if you have a question or want to discuss, come off mute. We don't have to do it by the chat.
It's Abraham. If I, hey Scott and Rebecca, if I send so we've got a group of like 600 residential beds that people are on buprenorphine, and if all I can think of is to send a nurse practitioner on site to see all of them, but it's way more than one person can handle. And so, and I tried recruiting this the last time that the DEA was going to do this, and I was only able to get one. This is all rural, and it's 50, 60 miles apart, each of these locations. And I was only able to get one nurse practitioner that would go on site. Once that nurse practitioner is prescribed, that doesn't help me at all, because the off-site nurse practitioner still can't take over for that person, right? I mean, they can't take over. She has to follow he or she has to follow those people themselves. They can't have the other nurse practitioners help them. Right?
Yeah, that's right. And I think I mentioned it, but the initial proposed rule, the one that never went into effect, did have the concept of a referring doctor, and that could have been utilized in the situation you're discussing, but not the original Ryan Haight Act if we went back to a scenario like that. I think the best scenario is, as you mentioned, getting somebody on site. Not necessarily helpful for you, but your comment did make me think of the possibility of going to people's homes. So for patients that have an issue leaving their home to come in for an in-person visit, their home care could cover an in-person visit if a nurse practitioner is able to do so. There's a very
And
long,
I can also tell you under the new NPRM that they're getting ready, that they want to put out, there is not that referral in there.
oh, there's not,
No, there's not.
but there is a special registration, right?
There's a special registration, correct?
Right. And so presumably, and I guess a question for Scott. So under the idea of a special registration, you wouldn't have to see the patient in person at all, right? If you had a special registration and prescribed compliantly with it.
That is correct. If you could meet all the requirements and guardrails of this special registration, yes.
Yeah, in our situation, unless it's extended, I can't think of a way we can fix this because we have 20,000 clinicians in our database, and we reached out to everybody and went beyond that the last time, and we were only able to get one nurse practitioner to go on site. And so, I mean, I think we'll have to tell them they'll have to shut the facility down or something. I don't know what they'll do.
Similarly to Abraham, we serve a very rural area in Southeast Georgia, and most of our providers are nurse practitioners, and typically they are not physically on site at all of the clinics. But even if they could be, with our child and adolescent population, many of whom take stimulant medications for their ADHD, nurse practitioners in Georgia, at least, are not able to prescribe stimulant medications at all. Only their supervising MD can, which would mean that we would not be able to serve a huge number of kids and teenagers in terms
Right.
of.
I don't think a lot of the nonprofits know about this. We were talking to a nonprofit in West Virginia. They have tons of patients on buprenorphine, and their nurse practitioners out of state doing all their buprenorphine for them. And I don't even think they know this train's coming. And we have a pharmacist that works for us, and he was telling me, well, you better be cautious, Abraham, because you're going to scare out the clinicians before this date even comes. Because I'm worried because we're going to notify the clinicians probably this week, and there's about 300 of them. And I think a lot of them are going to quit just because they don't know what to do. They feel like they're going to have to get another job.
It's a very delicate balance between setting everyone's hair on fire and
right.
making sure people are just aware, because it's September 30th. In a month, will we have more information, and will there be more progress?
Right. And if you're a clinician, it takes you 3 months to credential at a new job. So they can't wait till January, or they won't be able to make their home mortgages and stuff.
Yeah. I wonder, and I think, again, a question for Scott that I just thought of. Have you heard of any possibility of a buprenorphine extension on its own, or that's not anything that's been suggested?
But I know that when I had left DEA, we had completed the audio, we call it the audio only buprenorphine rule, and it was being held up in the process going through. But I encourage everybody to go look at the DEA's guidance document portal. There's a guidance document switching that audio only buprenorphine from the COVID PHE to the opioid PHE. So I would encourage everybody to take a look at that, the guidance document, because that is a possible route we've been kind of looking at to allow this to continue, even if the flexibilities do expire. But there's a lot of questions on the legality of it and whether DEA just forgot to take it down or not.
Oh, okay. Thanks. Well, I'll definitely.
But, yeah, and one thing I would encourage you to is to watch very closely as these new rules come out, the flexibilities on nurse practitioners or advanced practice nurses and their ability to do telemedicine, even under the new notice of proposed rulemaking that DEA is getting ready to put out. One of the requirements is going to be that nurse practitioners are state board certified in certain specialties in order to do that. And I don't think that any state has board certifications for nurse practitioners. So therefore, it will severely limit what nurse practitioners can do via telemedicine.
And they're all board certified, but yeah, I don't know whether that would be, as a matter of fact, the ones we have in Washington, they're double boarded. That's why they're so hard for me to replace, because
I
they're
mean, board certified in things like psychiatry or geriatric
Right.
care or things like
right.
that.
They're board certified. They're all board certified in psychiatry, and they're all double boarded in internal medicine, because we do the diabetes and the blood pressure and everything. That's why they're hard for me to replace on or get people on site, because they all are double boarded.
I see that Matthew sent a large excerpt from Pennsylvania. I didn't read the whole thing. I'm not sure, Matthew, if you want to discuss it or if that was just FYI.
It was just an FYI that DDAP, I represent a nonprofit, and on the 27th, and I'm emailing back and forth with Kim right now, who's the head of this department. We had the extensions on the Part 42. I put it in there. I didn't want to make it, but here's the interesting thing. So you're an office-based opioid treatment center, or you're an OTP, all right? If you read that, regardless of what the DEA is done, because SAMHSA and everybody kind of passed to allow exceptions for telemedicine initials done with prescribing meds. And they're basically, if I'm reading this correctly, and I went back with her, they're saying it doesn't matter in-person it's going to say you have to see them initially in person before you can actually prescribe anything. And that's even before the DEA comes out with anything. Our own state is pulling that back on the exemption. So
Which state are you in then, Matthew?
Pennsylvania, I can send you guys over the alert that came out. And I know, Kim, I'm going back and forth with her because I have a lot of concerns about that.
Is that for all medications or just controlled medications?
Well, the ones that I'm worried about, right? Well, controlled is still methadone, and controlled still bute is still controlled.
Right,
So
right.
that's effective. Like if the DEA is holding the buprenorphine stuff political capital right now, depending on where that falls in the classification, this is basically saying I cannot provide a bridge script for somebody who's trying to get into our physical facility on a Friday and then get them into our physical facility on Monday. If I'm reading this right, they're not going to let me do that. And this is before the DEA says anything.
Matt, you're correct, because CTEL just finished a 50-state prescribing survey looking at controlled substances at a state level, and
Yep.
8 states are more restrictive than what federal law would be.
Right.
And that's before DEA has come out with whatever they're going to come out with.
Yeah, that's a really good point about the states being more restrictive, because even if there is a proposed and final rule from DEA, it does not restrict a state from being more stringent and requiring something more than the DEA does. Even throughout the public health emergency, through today, there's been debate over interpretation of rules in New York, for example, about prescribing and controlled substances. But ultimately, New York regulators issued guidance saying that they would be consistent with whatever DEA does, essentially. So once these waivers expire in states like New York and Pennsylvania and others that may have been consistent with DEA, just like we're thinking about going back to pre-COVID Ryan hate, you'll have to think about going back to whatever was the law of the land in your state before your state decided to be consistent with DEA waivers and extensions.
Thank you.
Oh, you're welcome.
Welcome to the Commonwealth of Pennsylvania. We are a interesting place to be.
Oh.
I think the piece
you're on
that's-
mute, Krista.
Oh, am I still on mute?
No, you're good.
Okay. I think the thing that's most concerning right now is literally moments before we got on this call, we finished a call with Energy and Commerce. And it was very clear that this is important, but it's not necessarily a legislative priority of theirs, which is concerning. And there was some blame put on the telemedicine industry because the question came about, well, why are we just hearing about this now? And we've only been hearing about this for the last 4 weeks. Why haven't we been hearing about it consistently? We took that time to educate the staffer, but it doesn't seem like a legislative fix is going to be it. So Scott and Rebecca, should we just assume that with that, I mean, should we just assume that there's probably a 90% likelihood that we're going to be reverting back to pre-COVID standards as of January 1? Unless DEA comes out and gives us an extension.
Yeah, I think, well, I see Scott went off mute too. I think the hope of hopes, right, is that DEA does extend the waiver despite their current commentary that they are not inclined to do so.
Yeah, and you're right. I would start assuming that, start planning for it, but you know, political pressure does lots of things in this country. And you know, the more pressure you put on DEA, the better chances there are. And right now, I know the pressure is not very heavy on DEA. There are people writing in, but not huge numbers. So I put the 2 email boxes to send your letters to in the chat box, so that can be a start.
Yeah. And if anyone has any questions, you could message me directly. CTEL's putting together some policy strategy in terms of research that we could hand over to the committees, and also working on potentially a dear colleague letter with the hopes that that might go somewhere, but we're not too optimistic about it. We have Liznette, if you wanted to go ahead.
Right. Do the panelists have any thoughts about the interplay between the end of telehealth flexibilities and state requirements for continuity of care of patients? I think that's a really good point. And, you know, I said it probably too much in like jest that doctors say, you know, DEA be damned, I'm going to keep writing scripts. You don't want to harm your patients, right? And I think you do have an ethical obligation to prescribe something for a patient if they need it, and that'll have to be balanced with what the law is. But the reality is that if we really go back to these rules, I don't know that there's a pharmacy that will fill the script if they know it's coming in via telehealth. But I do think, you know, more to even ignoring controlled substances, or not ignoring it, but even aside from controlled substances for the moment, physicians, the rule is you have to have a medical license in the state the patient is in, right? That's to write a script. So if your patient is on vacation in another state and you're not licensed there, but they need a refill on their script, right? They need it, they forgot it at home. I think 9 times out of 10, the prescriber writes the script, even if they're not licensed in the state that the patient is, because they have an obligation to continue that patient's care, and an ethical obligation to make sure their patient does not go without a necessary script. So I think decisions like that are case by case, but it's definitely a concern. What is that? I heard that Buddy Carter and Mark Warner were possibly interested in legislation to provide a fix. Has anyone else heard this? That's probably more towards you, Krista. You're on mute.
Sorry, I was responding to a question on the chat, in the chat. Can you ask let me see, where is this?
Alex Millie's question. Oh, not Alex, Sheila Franklin's question.
Yeah, I mean, we've heard that too. There are members that are interested in a legislative fix. What we have heard from Congress, though, is that, especially today when we spoke to Energy and Commerce, is that this is really considered a very polarizing issue, and not all members of Energy and Commerce support an extension. Now, when we're talking about what the Senate is looking at, the Senate is putting forward the Support Act, but the Support Act doesn't necessarily have language in there that would allow for, that doesn't include HR 7899, which is the House legislative, the House vehicle, I'm sorry. It is the piece of legislation in the House that would be the vehicle for allowing the extension, but the Support Act doesn't include language from 7899.
Oh, go ahead.
Yeah, sorry, there was one question that was asked in this chat that I can answer. Have there been any studies showing a large increase in appropriate prescribing? I assume that that's involving telemedicine. that is one of the big problems with DEA and putting the guardrails in, is a lot of people did studies on how great telemedicine is, but nobody did studies on how much diversion telemedicine has. So what DEA is relying on is there are huge cases now that have popped up since COVID hit. You know, these large telehealth companies that are just prescribing stuff everywhere. So now DEA sees that as a problem, and there's no studies that it's not, people decided that not to study to see if there was diversion when they did the study. So there's just nothing out there. So DEA is reacting based on the cases that they are working. So that's where they're getting now, all want to put all these guardrails in because they're seeing a huge increase in criminal cases involving telemedicine.
But Scott, is it really telemedicine? Because we've had this conversation before. If there's not an appropriate examination and they don't meet the medical standards of care and they don't meet the very definition of what telemedicine is, it's nothing more than basically a prescribing mill, and it's taking place via the internet. So it shouldn't be called telemedicine. It should just be called an internet scam. And telemedicine, unfortunately, is getting a bad rap in the end.
No, I agree with you. But if you go to their website, they talk about telemedicine. You know, and that's where it gets the name and the thought. But you're right, they are pill mills. And
Yeah.
this is what DEA had a problem with before the Ryan Haight Act with oxycodone and hydrocodone. Ryan Haight Act happened, they went away, COVID happens, and now they're back again just with different things. You know, so that's how DEA sees it.
There was a press release today. I see the enforcement actions as they come in every day, about doctors, a pair of doctors that were signing prescription pads for controlled substances and not seeing patients, and they're going to jail. And of course, that's bad behavior, that's fraud, and that happened in person. You know, so that kind of activity has been happening since forever. And whether it's via telemedicine or not, you know, to echo what you're saying, Scott, there is no study to say whether there's an increased risk of diversion through telemedicine.
Yeah,
That's a good point.
Yeah, the only difference, Rebecca, between what you are saying is, you know, a doctor writing pre-signing scripts is a small area that's affected. A doctor that's doing it, these online things, it's a whole country that's affected, and there's thousands and thousands of prescriptions.
Yeah. And those were the online pharmacies that Ryan Haight took down,
Exactly.
and they really did when Ryan Haight first came out.
Yep. Abram, did you have something?
Oh, I was just going to say, yeah, it was kind of the same issue. I think that, you know, if somebody's a bad actor and they want to engage in diversion, the in-person visit doesn't necessarily stop that. It doesn't really make any difference, actually. I see what you're saying, though, in terms of they do have a wider scope, although clinicians also get flagged, you know, for how many people they have on their caseload. So it's highly unusual for, I mean, they are generally limited, but I guess maybe maybe you could try and go above that. But nurse practitioners, whether they're doing in person or internet, they're still probably got a caseload of 500. So it, even though it may be over different states, it's the risk probably isn't that much greater. Although I guess I understand what they're saying, like about places like Cerebral and Dunn that had some really bad situations happen.
I do want to respond to Alex's comment asking about prescription medical devices and uncontrolled substances. So important to note, we are only talking about controlled substances here. The Ryan Haight Act only restricts the prescription of controlled substances without an in-person evaluation. With respect to non-controlled substances, it would revert to your state law. And most states do permit some form of writing prescriptions for non-controlled substances via telehealth. Some have very specific regulations about whether you can do so via a questionnaire. And if it is a questionnaire, does it have to be, what's the word, static or dynamic questionnaires? But for non-controlled substances, for example, contraception, like birth control, for antibiotics, for, you know, your kind of everyday primary care type drugs, none of those are restricted by this DEA rule.
Thank you.
You're welcome.
One other kind of just interesting note is the buprenorphine obviously is a huge issue, but on the stimulants, I mean, they're evidence-based for kids, and 99% of what we do with regard to stimulants is for kids. We don't we rarely ever write stimulants for adults. I know that some people have adult ADHD, but I know all our clinicians at least are much more skeptical when it's an adult. We know kids aren't going to be doing, generally selling their Adderall or whatever. You do have that concern when it's an adult, but anyway, it's just something to think about. And plus, it's one of the best treatments for kids with ADHD, so that's another thing to consider. But I don't know whether the DEA ever thought about breaking out adults and kids with regard to restrictions on Schedule 2.
Yeah, I do feel like with the opioid epidemic that unfortunately children and adolescents are being overlooked in that regard, and the fact that there are such strong restrictions on the first line treatments for ADHD, and I mean I just see that as a huge problem. Of course, I'm a child and adolescent psychiatrist, so that's my bias, but I agree
Right.
that there's
Right. We had a clinic that
comparing apples and oranges here.
Yeah, I agree. We had a clinic many years ago that every patient we got, the primary care doctor who was seeing them in person, started them on Xanax and Adderall, those two medications. And so everyone we saw on telemedicine, we took them off Adderall and Xanax. And of course, they want to kill our doctors, but the doctors are very conscientious. They're not interested in, supplying people that are using Adderall or Xanax. And there's no, I mean, as far as I know, I'm not a doctor, but as far as I know, there's no evidence-based intervention that requires Adderall and Xanax.
I see Scott's answer and Lizette's questions about timing for a proposed rule. I guess more to you, Scott, could a proposed rule be issued as late as December 1st? I think it could be, but it would be impossible to be finalized because even if there's a 30-day comment period, DEA has a responsibility, or I think a responsibility, to read the comments that come in. And there'll probably be, thousands and thousands, just like last time, which if it's done right before Christmas, they'll not have enough time to finalize.
Yeah, no, I can tell you there's not enough time to get a final rule out anymore. The deadline has passed for that because you have a 30-day comment period. When we had got 38,000 comments, it took 25 of us 30 days to go through all of them and organize them. And then it took us another 30 days to start writing the final rule. And there's such a huge review process that it will take months for the review process. There's not a path to get this finished by the end of the year. Unless the only way I could see a path is if the president called up the administrator and said it has to be done.
But if there were a successful push for an extension, just a 12-month extension, something like that, that doesn't have to go through all that timeline, right? That can be done much quicker. Okay.
I think we did the first one, the first and second one, like 10 days. It is pretty quick.
Yeah. I mean, that seems like, as far as pressure, we need a rule. There has to be a rule because you can't extend waivers forever. But that's the highest likelihood of success, pressuring the DEA to extend the waiver.
Yeah, and it's not fair to the general public what DEA has been doing and waiting till the last second to do an extension. I believe the May 11th extension at the end of COVID, we published on May 1st. That the hospitals industry need to start preparing now. You can't wait till the last minute to publish the extension.
Right, absolutely. I mean, we're making appointments for our patients right now, and into the next year, and so yeah, that kind of back to the debate we were having before. It's like it's hard for me as in operations to know whether to go ahead and let that cat out of the bag and have all my providers panicked, or to see what's going to come of this, and because we do it seems simple to just, oh, we'll just check and see if you've seen them before, but building all that into the EMR and everything is just can be a challenge.
So I know we are 2 minutes over time, but if anyone else has anything, I'm happy to stay on for a few more minutes. If not, I guess I leave it to you, Krista, to finish up.
Do we have any more last minute questions? Rebecca and Scott, would you be interested in sharing your contact information in case
Sure.
those on the panel might, or some of those on the webinar might be interested in talking to you?
Do you want me to put it in the chat?
Yes, please.
Sure.
All right, well, thank you so very much. And if you have any questions, please feel free to reach out to me. I dropped my contact information in the chat, or you can just reach out to CTEL at info@ctel.org. Thank you, everyone, and hope you have a great day.
Thank you.
You.
Bye.